Good evening, everyone. My name is Michelle Galazewski. I'm a Partner Relations Director with Eversight, and on behalf of everyone at Eversight, I would like to thank you for joining tonight's program, Taking Control of the Situation, Reconstructing the Anterior Chamber with the Artificial Iris in DMEK Surgery. In an effort to eliminate all background noise, all participants will be muted throughout the duration of the webinar. If you would like to ask a question, you may do so by typing your question into the Q&A panel at the bottom of your screen. We will address all questions at the end of the webinar. At this time, I would like to introduce our speaker for this evening, Dr. Donald Tan. Dr. Tan is a clinical professor in ophthalmology at the Singapore National Eye Center and Duke National University of Singapore Medical School, and a senior partner at Eye and Cornea Surgeons. His clinical interests and research are in development of corneal transplantation techniques and surgical devices, and in myopia control therapies. A past president of the Cornea Society, Dr. Tan is also the founding and current president of the Asia Cornea Society. He was inducted as a member of the Academia Ophthalmologica Internationalis in 2018 and currently serves as an international trustee at large for the Board of Trustees of the American Academy of Ophthalmology. Dr. Tan, you can begin.
Thank you very much. Good evening to everybody. Good morning to everybody around the world. I'd like to thank Eversight for inviting me to give this webinar. I've called this talk Taking Control of the Situation, really for those cases of DMEK that we find quite challenging. And the idea really is to try and build in a little bit more surgical control at different stages of the procedure, so it makes our lives easier. So these are my financial disclosures. Network Medical Products makes the Tan Endoglide, which we are using in this presentation. So we look at the last, let me just move this on. So let's look at organ transplant, corneal transplants, and the survival rates compared to, say, solid organs. This paper came out in the British Journal of Ophthalmology about 10 years ago. And it really wanted to compare how corneal transplant does today in the modern era compared to, say, renal or liver transplants. And this is a study done in the UK. And it sparked a commentary called Corneal Transplantation, How Successful Are We? So here you see survival curve analysis up to 10 years of renal and liver transplants, Kaplan-Meier survival. And if you superimpose the data from the UKTS, the British corneal transplant data, you see that all corneal transplant, all penetrating keratoplasties, PKs, they do only about as good as renal transplants. Now, we've heard in past in the textbooks talk about immune privilege and the cornea is avascular and so graft survival is better. We don't use systemic immunosuppression, but at the end of the day, we're only as good as renal transplants. If you then split up PKs into all PKs versus high-risk PKs, in fact, we are worse than liver transplants. So the challenge really facing us is that PK graft survival rates are only as good as renal transplants. And if you're high risk, for example, repeat grafts, you do worse than liver transplants. So that's really something to think quite hard about. As we know, there has been a paradigm shift away from PK in the last 15 or so years. And this was taken from a paper which I was fortunate to co-author with Ed Holland and Kinoshita and John Dart in the Lancet. And you'll see we now have a plethora of different types of procedures. On top is PK, but you now have, we had DSEK, which is quite standard now in the industry. We doing a lot of anterior lamellas, whether it's pre-descemetic or descemetic DALK, deep anterior lamellar keratoplasty. And of course, DMEK is the latest iteration. Now we look at the reason why we're going to lamellar surgery. It's quite clear now that there are less postoperative complications. For example, rejection rates. Because we're transplanting less tissue, our rejection rates are lower, and these are just taken from various studies. This is from the Singapore corneal transplant data study, which covers about 5,000 transplants over 15, 20 years. And you see that DMEK has very low rejection rates. DALK DSEK, all much lower than PK. And PK rejection rates overall about 14%. The challenge with this is that surgery is more difficult. And obviously, if there are surgical challenges and problems, then it's not only a long learning curve, but your initial graft failure rates and immediate post-op complications are higher. So the balance is really whether we have improved graft survival rates. And I've shown in previous talks the studies from, say, the Australian corneal graft registry, which actually shows that lamellar surgery can have worse outcomes, really because of the surgical challenge, not the physiology of performing lamellar surgery. So how do we make life easier and enhance survival rates? Well, this is data again from the Singapore Corneal Transplant Registry, and it clearly shows two complications, our major complications after corneal transplants, glaucoma and rejection rates. And you see that PK has much higher rejection rates and glaucoma because they go together, because if you have high-risk rejection, you're using steroids for longer, you get more glaucoma as well. And if you look at DMEK and DALK, they have the lowest rejection rates and glaucoma rates. Lower glaucoma, and DMEK, in fact, lower even than DALK. The graft survival rates, the statistical significance is below, comparing all the two, but basically, DMEK and DALK are the way to go in terms of long-term complications. And perhaps this is the reason why, in addition to the better visual performance of DMEK, we should really be trying to perform DMEK, especially in your high-risk cases. This is a study which we published, I think came out earlier this year, and we looked at the 5-year outcomes between primary grafts for two conditions, Fuchs endothelial corneal dystrophy and bullous keratopathy. And we compared the 3 operations that we've done over the years, 400 PKs versus 400 over DSEKs and about 120 DMEKs. And you see a stark difference. If you look at the Kaplan-Meier curve on the right, you can see clearly that DMEK is much better than DSEK, and DSEK is better than PK. So DMEK had the best outcomes, followed by DSEK. So here's all cases. So your 5-year graft survival for PK, only about half survived, so 54%. DSEK, about 3/4 survive 5 years, and DMEK, 97%. Now, the challenge, of course, is a lot of it depends on the indication. If you look at the differences between Fuchs and bullous K, you start to see a difference already. So for PK, the Fuchs dystrophy is still about 70% compared to less than 50% for bullous K, and same for DSEK. But if you look at the DMEK group, we're really in your high 90s. So if we split this chart by disease indications, you see on the left here Fuchs dystrophy, and of course in the West, in Europe, Fuchs has got the highest incidence in terms of, say, DMEK or DSEK. You see that, DSEK and DMEK all do very well, PK not as well, but the challenge really is not Fuchs, it is bullous keratopathy. Other forms, whether it's glaucoma, pseudophakic, aphakic bullous keratopathy, you see that there is a spread now, and DMEK is clearly better than DSEK. So in Asia, we have more of the bullous keratopathy, and they're obviously they come up with a lot more comorbidities, and that's the challenge that we have today. This is my good friend Rajesh Fogla from India, and I think this is the nicest video I've seen of a perfect case and a perfect DMEK. He did this as live surgery for the Asian Corneal Society. Very cool. He did it in about 5 minutes, and very good tapping technique. And it takes a long time to learn this technique. The advantage here is that the anterior chamber is normal. The view is pretty good, and there's no peripheral anterior synechia. The pupil is small. A perfect case. This is not what we often see. We often see this. In this situation, I think it will take a little bit longer. DMEK can be done, but there are challenges. So poor visualization, firstly. And secondly, there's peripheral anterior synechia in the periphery. There's a large dilated pupil. The IOL is just there. It looks a little bit decentered. In fact, the chamber is abnormal. There's an open capsule. There is vitreous on the side there and an unstable IOL. So to do this type of tapping is going to be very difficult. And when you're first starting off on DMEK, these are the sort of relative contraindications which suggest that one should not try and do DMEK in these cases unless you're very skilled. So aphakia, if you have blebs or valves, ACIOLs, obviously, prior vitrectomy, peripheral anterior synechia, aniridia, and previous failed grafts. These are all major challenges. So I've been trying to decide and see how can we make DMEK easier? How can we democratize it so that a lot more people can perform DMEK easier as well and make it more predictable? And then also, can we do these procedures in more complex or challenging cases? And over the years that we've come up, the concept has been trying to enhance surgical control. So firstly, how can we control the DMEK graft better? You can't touch it, you just have to tap it normally. And so the pull-through technique, which we really knew how to do this, learning when we first started to do DSEK, whether we use the sheets glide, the Busin glide, or the endoglide, but basically using forceps to physically hold and grip the tissue and pull it in. And you can do this for the DMEK graft now. So there are various techniques for the pull-through technique. Secondly, to enhance surgical control of the anterior chamber, we devised the endoglide for DSEK. Once you place this device in, this delivery device in your anterior chamber, it is a sealed chamber, and with an AC maintainer on very low flow, you can actually control flow in the AC. And as being a closed chamber, there's no flow, and the AC maintainer can be put on very low flow to shallow the chamber or a slightly higher flow to deepen the chamber. So we want to be able to enhance control of the graft and control the anterior chamber depth. So there have been two conceptual changes regarding surgical control of the donor with this approach. First, through the pull-through concepts, so you're actually holding in. It also means that there's less risk of having an upside-down graft. So nowadays, I don't mark the tissue or anything like that. As long as I don't let go, it can only be the right way up. Okay, prevent the tissue from dropping to the vitreous cavity, shooting out through the wound, etc. And secondly, part of the pull-through concept is to have the tissue coiled, pre-coiled endothelium in, or the endo-in concept. Unlike the natural tapping where we let the tissue coil endothelial out, which actually is more challenging in a way to allow it to unscroll, here we are pre-coiling it endothelium in, which protects the endothelium during the delivery. And so this is the concept of the endo in. It's much easier to unscroll. So this is conventional tissue. Here it's already almost unfolded, but you'll see that it is normally coils endo out. And what happens then is the surgeon has to indirectly, and that's the way the tissue wants to scroll, and the surgeon has to go against the natural force of the tissue to unfold it. Contrast with the pull-through technique where here you can see you're holding it with forceps. It's still the right way up, but you've pre-coiled it endo in, and therefore the natural intent of the tissue is to uncoil the right way anyway. So you're using the springiness of the tissue to help you to unfold it the right way. Over the years, there have been many approaches for DMEK. About 8 years ago, we presented at ASCRS Cornea Day a technique where I used the endoglide, which is used for DSEK, and a prototype Descemet's matte type device, and we published that, but we moved away from that. And then Busin did the same thing. He used the contact lens to deliver the DMEK, but again, coiled it in endo in. He published that as well. We did a hybrid technique, which we published a couple of years ago, where we used the DSEK endoglide, and we just pulled the DMEK in. And we did that, and that's just been published as well. And Busin then followed up with another paper in AJO where he used a preloaded tri-folded donor in an IOL cartridge. Today, the endoglide comes in two forms. It's from Network Medical, the DSEK, which is known as the ultra-thin DSEK model, and a DMEK model. This is the standard ultra-thin that we use for DSEK, which has been around for almost 10 years now. And this is the new model, which has been around for the last couple of years. We call this endoglide DMEK or eDMEK, and published this very recently, the study to show the safety and efficacy. And you see basically the differences on the left here. On the top is the standard cartridge, which is standard width, goes through a 5 mm incision, and the DMEK is lost weight, skinnier now because the DMEK roll is much smaller, and it goes through about 2.6, 2.7 incision. So this is the procedure. After stripping the tissue, we carefully create a trifold. So this is endo in, we're folding the endothelium in into a coil, into a trifold. One area is a little bit, the advancing edge is slightly narrower, and basically we deliver the whole tissue to the endoglide device, and we're gripping the tissue, just pulling it straight in. Okay, so once it's in, we know which way is up, it won't rotate, and we basically place it in through the wound, and I'll just show you simultaneously here. You can just make sure it's there, and it goes through a clear cornea, 2.6, 2.7 millimeter wound. There is an AC maintainer. If you notice, I put it right across so that when the flow comes out, it actually helps to billow out the tissue. And I'm basically bringing the tissue to your AC maintainer, which is on very, very low flow. The chamber is sort of semi-shallow here. And as you can see, it automatically starts to uncoil. And I'm using the tip of the endoglide really to just close the wound briefly each time to deepen the chamber, and that allowed the tissue to uncoil. And if one side doesn't uncoil, then you can just inject an air bubble underneath. So this creates quite a lot of control in the situation. You can have challenges sometimes, but generally a lot more control and less risk of donor eversion. So in the original paper, which is was published actually just in May this year, we did this in the lab, and we looked at some paired donor corneas. We stripped both of them, and then one we pulled through like this, and the other one we just left it alone. And you see there's about 10% cell loss. You can see a bit of forceps damage. But bottom line is that the controls, where we just stripped the tissue, you already lost 13% of the cells. And with the pull through, we didn't really increase that loss. So 15%, there's no difference. So you can do all of this, and you don't actually damage the tissue that much. Here's a more challenging case. So now we're getting to the more interesting cases, and you can still do this. Here, there's a bit of iris loss, but not too bad. The view is poorer, but the chamber is still more or less normal. There's no peripheral anterior synechia, and you can manage this. And so I started on doing quite a lot of these more complicated cases, including regrafts, vitrectomized eyes, and tubed. And yes, we can do this. All right. And what we would do is there's peripheral anterior synechia. We would break the synechia, remove all the scar tissue in the AC, deepen the chamber again, reform the peripheral angles, and then you can do DMEK in these cases. And we've done, I'm not sure how many now, I think we've probably done close to 200 cases, my guess, at Singapore National Eye Center. There are a couple of surgeons, 2 or 3 surgeons using this technique, using the DMEK endoglide. And I've been doing quite a lot. So this is the publication below, but basically we are able to convert these. And you can see some of them are quite complex eyes. On the bottom here, regrafts after previous failed PKs or DSECs. Mostly all you will see are pseudophakic bullous keratopathies. Overall, in our original paper, which we had about 70 cases, the cell loss is still, considerable. It's still about 33%. And that's about the sort of standard average for DMEK. But it does include a fair amount, about 30, 40% of cases were these more complex cases. So with this standard tapping technique, the no-touch tapping technique, certainly it is the standard today. And what we're doing is, of course, we're applying indirect pressure through the surface of the cornea, and that creates fluid waves to unscroll this tissue. Now, it's really important then, if you see this, that what we're really doing here is that we are trying to use the chamber itself to have these fluid waves. So we need to have fluid coming back, transmitted to the donor from the back of the cornea, but also the sides and the iris. So this whole closed chamber concept is very important to allow us to tap. And in abnormal cases where the anterior chamber is not normal, Here, for example, is a deep chamber. We all know that you can't do, or it's very difficult to do DMEK, say in a vitrectomized eye, or God forbid, an aphakic eye, you know, and the iris is floppy. So you may never even be able to unscroll. There's nothing to tap against. There's no posterior surface. So very difficult. If you have missing areas of iris or iris defect, then again, very difficult challenge there. Aphakia, you don't want the tissue dropping in. So there are issues there. And if you'd have to tap against an ACIOL, then of course, I think there could be more damage as well, because you're tapping onto endothelium onto the ACIOL. So when we have abnormal iris cases, there comes the challenge, and it's very difficult or more challenging to do your standard tapping. So moving along and thinking about how to handle this situation, I realized that the AC is the problem. These are some of these cases. So here you will see whenever we have anterior segment disorganization, mostly from previous cataract surgery or glaucoma surgery or angle closure glaucoma, or any of these sort of cases, or a previous PK in which the chamber has been abnormal, the iris is abnormal. The iris a lot of the time is distorted, it's widely dilated, it's no longer functional actually. But more importantly, it's also stuck to the angles, peripheral anterior synechia that shallows the chamber. And often these eyes are also have an open vitreous compartment. The IOLs may also be a bit unstable as well. So how do we handle these cases? This is the challenge facing us if you're going to try and do a DMEK. And most people quite often would try and do a DSEK, or worst come to worst, just do a PK. So here, your anterior chamber is limited by peripheral anterior synechia, iris adhesions, IOLs and tubes in place, and there's inadequate posterior surface of the AC. So either aniridic, dilated pupils, an open vitreous cavity, or just aphakia. So I want to introduce one more important conceptual change in DMEK surgery, and that is to try and create back and restore this artificial chamber. So restore or reconstructing the AC means to reconstruct the elements of the walls of the anterior chamber so that you can now perform DMEK more easily. That means restoring the angles. So PAS, which is our enemy, and PAS also, by the way, quite often attaches to the graft-versus junction and brings in new blood vessels and is one of the risk factors for graft failure because of lower cell counts and rejection. So you need to perform synechiolysis, release the iris tissue and the scar tissue, quite often adherent decimase to the iris, and to really clear the decks, so to speak, to pave the way for DMEK. Not only that, important aspect, once you clear the actual anterior chamber, you still need a posterior surface. And to restore the posterior surface. An important aspect about PAS is that, and a lot of people who do grafts, whether it's DSEK or DMEK or PK, is that the PAS tends to recur. So you can separate the iris from the cornea, but over the next few weeks to months, you will see that iris zipping up and sticking back again. But to restore the posterior surface of the ACIOL, firstly, we have to make sure that the IOL is stable. We should remove the anterior chamber IOL, exchange it for a sclerofixated or a transscleral fixation of a posterior chamber IOL to get it out of the anterior chamber. Make sure it's stable, and then try and restore not only the iris, but the pupil. So that means removing abnormal iris and replacing it with a normal looking artificial iris. And this is the concept which I'm talking about today. So these are some cases, and can we do this? All right, and you can see the chambers are a lot more normal here. And so the two concepts to consider are control of the surgical environment. So now that we can control the donor, can we control the environment? And therefore, we have to reconstruct the anterior chamber to facilitate donor placement. And then you can do your pull-through. So you control the AC first, set everything up, and then you control the donor during DMEK by using the pull-through technique. The human optics artificial iris called CustomFlex is now available in many countries. It's FDA approved for the last 2 to 3 years, I think, in the US, and it's used mostly in complicated cataract surgery, where there is aniridia or a missing segment. This artificial iris is made out of silicon, comes with a whole iris shape like this. It's about 12.8 millimeters in diameter. So you can refine this to whatever size you want. And most surgeons, a lot of the time, to have large iris defects, to solve those, they will cut this up into segments, right size, and just suture it in place. You can also place this in the bag in a capsule for anterior patients. And it comes with two options, with fiber and fiber-free. With fiber means it has a mesh, which makes it more resistant to suturing. And therefore, if you are using this implant in an unstable situation where you're not putting it in the sulcus or the capsular bag, and you need stability, just like a sutured IOL, you can suture this in, and most people will use Gore-Tex sutures. And the fiber version is the one to use. If you are going to insert this in the bag and you're not going to use sutures, you get a fiber free. Now, my experience with this has been all with the fiber version. You can use a fiber version for even in the bag placement, as I'll show you. So you have to be careful that you understand which one you need to order. It comes up in two different colors, basically blue or brown, but they do have a custom version where you can take a photograph of the patient's other eye, send it to the company in Germany, and they will reproduce the color. But I've been just using the brown one, which is pretty standard, and that's fine. It's made of silicone, and it's suturable, and it's slightly floppy, but it's not like the normal iris. So this is for suturing. So my approach, if you look at the various videos and the website, you have to be registered and go through a training session to be approved to order this iris. They usually will, there are lots of videos showing how you cut it up and how you suture it or put it in the bag. But if you're suturing it, all of them basically have 2-point fixation, because we all learned this from an IOL, where you have basically 2-point fixation. I've modified this approach for DMEK. And the major modification is that I use 4 sutures. Now, this doubles your operating time, but doesn't make it any more difficult, just makes it longer. But if I have a suture in each quadrant, and these are mattress sutures, then this implant is really very, very stable. And it will not tilt. And more importantly, what happens is that if you have a 4-point fixation, you know, this iris is unattached in the periphery, and there is always a gap, and we know this with the old mortar IOLs, and we've had DSEC grafts slipping through the edges along the scleral walls. So at least if you have one quadrant in sutures in each of these quadrants, and that will not only stabilize the iris, but also help to prevent the unfortunate event of a DMEK graft slipping through. So that's one modification. I do everything here. I pre-mark first. And here's really important point. Normally they would say you would put it around the pars plana, so about 2.5 millimeters behind the limbus. That's where your sutures will go in. Those are your incisions for your sutures. I place it a little bit more anteriorly. And so my favorite usually is 1.5 millimeters behind the limbus. The reason is that we're going to do DMEK in these cases. And so we want a perhaps slightly shallower chamber rather than deeper chamber. So when you place this artificial iris, where the peripheral iris was, you could either place it around the same plane, you can place it slightly anterior, or actually, you know, sometimes you can leave some iris behind as a target and place the iris behind, the artificial iris behind the natural iris. And I would not recommend that, because the chamber becomes very deep. So it's important to get some idea of how deep you want to place this iris to make your DMEK easier. They always recommend refining this, because 12.8 is pretty large, and you usually measure the standard, and I find that fine, the white to white diameter on the table. And if you're suturing this, it's 1 millimeter less. So if the white to white is 12, my usual size is maybe 11 millimeters. I'll just use a standard PK Trefine. And you can see here, it's already, I've trefined it. And I've used Gore-Tex sutures, and these are mattress sutures that we've used to secure the implant. This is then either folded in through, the incision size will vary depending whether you're using a folding or you can use an IOL cartridge. But on average, I tend to make about a 4 millimeter wound. I can use forceps in this case, and it's quite standard. You just insert this in the usual manner, similar to an IOL, I suppose. What I use is the EndoGlide forceps. So I made pre-placed incisions with partial thickness groove in between. And here I'm using the endoglide forceps. These are the forceps which you have to use with the endoglide. And they're standard 23 gauge forceps, goes through an MVR blade incision. And I basically then just pull the sutures out, retrieve them, and you tie them and just gently tighten and make sure that the implant is centered. And then once that happens, you tie the knots, you rotate the knots, and I usually cover up incisions, and I'll show that in the video, and that's the procedure. It's important not to overfill the chamber with viscoelastic before you insert it, because what can happen is if that IOL is just sitting in the sulcus or it's just transscleral fixated, without any sutures, if you put a lot of viscoelastic, you introduce this bulky iris, you can dislocate the IOL. That would be pretty tragic, okay? And then once we do this, I now staged the procedure. I have to do all of this in one stage and not do the DMEK at the same time. That's usually bleeding, there's fibrin and everything else. So we wait for everything to settle down and then perform the DMEK a few weeks later. So here's a video, which we can start. Oops. So it comes in liquid there. Take it out. I just evert it. There's a nice stand on the opposite side, and you can trephine this, standard trephines. I just rotate it around just to make sure I'm roughly centered. I just look at it at all angles to make sure it's in the center. It's quite hard to trephine this, so you need to put quite a lot of force in. You can, even if you don't cut through, you can just trim it off, and that's it. So this is this is actually a 10 millimeter, and I'll show you this patient later. And then you suture the implant in 4 quadrants. I just use one suture, one long Gore-Tex, and I just go along, so I save costs. I don't need the needles anymore. I cut the needle off. There you go. Okay, so we're already there, and that's the preparation. Okay, so this is one of our patients. She's a 68-year-old female, complex pseudophakic bullous keratopathy. She came from overseas and had a really bad time with a standard, what turned out to be a disaster phaco. Back in February 2019, there was a PCR, nucleus dropped in. They did a vitrectomy and they put in the IOL, and that dropped in as well. They were going to fish it out, and then there was severe, they began to have a choroidal. So they quickly just closed everything up, abandoned the surgery. Then a few weeks, about a month later, went in again, did a vitrectomy, retrieved the IOL, and did a sclerofixated implant, which was okay. Implant's in place, but you can see the anterior chamber is pretty damaged. The pupil was fixed and dilated, peripheral anterior synechia, and then the cornea then decompensated. So the patient gets about 624 vision, fixed dilated pupil, and about 3 quadrants of peripheral anterior synechia. So the concept here is to normalize AC first, restore the iris morphology, and then secondly, perform DMEK. Here's that patient. Now, I'm going to stop the video here. You can see that I pre-place. I like to make sure I'm quite central, so I'll put the 4-quadrant marker here. This is a standard PK marker or RK marker you can use. I've done limited peritomies, and these are partial thickness wounds. You will see 1.5. This one is one of my first few cases, so this was 2 millimeters behind, but I would recommend 1.5. In a partial thickness slit, this is about a 2 to 3 millimeter incision, partial thickness, and then on either side, I would penetrate through with the MVR blade, make sure that I can see my blade going through the iris here. I can see it behind rather than in front. So this helps you to gauge. And once you've done all of these stab incisions, then this is the marginal dissector to break the peripheral anterior synechia. This marginal dissector is from Asico. I use it for DALC, but it's great to break any peripheral anterior synechia. Here's the pre-placed iris, trephined and sutured. And then I put it through, in this case, it was a 4.5 millimeter incision. I have to be careful not to dislodge that IOL. And the fortunate thing, of course, is we're going to do a DMEK anyway, so we don't have to be too, worried about damaging endothelium here. I'm more worried about not displacing that IOL. A little bit of manipulation, you can see it opens quite nicely, and then I fish out the incisions. What I haven't shown here is I've already removed that peripheral iris, some of it. I've done a vitrectomy. I tend to use a vitrector to cut away the iris. Don't want to pull, you get hemorrhage. So at the end of the procedure, these incisions are closed with, scleral incisions are closed and the conch is all closed up. And that's the end of that procedure. So this is what the patient looked like post-op. You can just see the sutures here, but basically it's a well-centered iris implant. This pupil diameter is of course fixed. I think it's 3.4 or 3.8 millimeters. It gives you a good view of the retina. And this is about a month later. You can see the eye's quiet. The iris looks pretty normal. The chamber is normal. And really the whole concept is that now this is almost like a normal DMEK. Okay, good thing is air stays here. So the chamber doesn't collapse. You can get it a little bit shallow, but it won't collapse on you. And you'll see that the procedure for all these cases is very similar now. And now that you've normalized the anatomy of the anterior chamber, the iris is there, then the procedure becomes really quite straightforward. So this procedure becomes like a normal case. Now the chamber can be a little bit deeper than normal, but I don't see it as a big problem. The chamber can shallow, but it will not collapse. So in a way, that's quite good. And because it's important it won't collapse, because this is silicon as well, you don't really want the endothelium onto directly plastered to the artificial iris. And I haven't encountered that so far. And really then that's quite easy now. So it's a pretty standard DMEK now. This is what the patient looks like. Amazingly, this patient achieved 20/25, 6/7.5 vision in 2 weeks. And it's been a year since we've done this case now, one of our first few cases. And this patient has a cell count of about 1,800. This is her other eye, just to show you in compare and contrast. So quite similar. Here's a 61-year-old lady who has got aphakic corneal decompensation, originally a congenital cataract, aphakic eye. And the issue here is a very updrawn pupil, glaucoma tube as well in place. She's got secondary glaucoma. She's amblyopic and has nystagmus, but vision was about 660 or so, but then became count fingers vision. The other eye is worse, so this becomes very important. And as a corneal decompensation, she came to see me. And in March this year, I excised the iris and did the artificial iris implant. And I've excised the iris here already. And in this case, you will notice that I've pre-placed the sutures because this is an aphakic eye. Okay, so we don't want this dropping in. Her other eye is aphakic, so we didn't want to put it in an IOL. And you can see that having the pre-placed sutures already pulled through really allows you to control that tissue. All right, so this procedure, this stage is under general anesthesia. It does take a long time. On average, by the time you trim the iris and everything else and do the vitrectomy, stabilize iris, it's probably a 2-hour procedure. But just take your time and go through all of this, and basically you're trying to normalize the AC. All right, and you can see here that slit. It's important because we bury the knots, and then I will then suture this. You see that's a partial thickness incision. So to prevent any leaks, I will use maybe 2 or 3 sutures just to close that up. And then close the conch. This is what it looked like post-op. So now you have a normal centralized pupil. The chamber is reasonably deep. And then the DMEK procedure itself. And again, it's pretty straightforward. Pull through. So you will find this boring by now, but you know, we like, as surgeons, we like boring. We don't want nasty surprises. And what this does is it makes DMEK boring, which is just fine. Okay, so no nasty surprise, or less anyway. You know, here I'm just tapping the wound, it just closes, deepens the chamber a little bit. So you can still modify the chamber, you know, position with this iris. It is still flexible. And I tap, I call this unintelligent tapping. So unlike Fogler, you don't have to be too intelligent when you're tapping here because you're holding onto the tissue. And sometimes if one side doesn't unfold, you just use the air bubble. I'm still holding onto the tissue, mind you. Okay, the downside of this technique is this wound is about, you know, 2.7. So you have to be careful there. And this is what it looks like. And she's back to 6:30. This is the best vision anyway. She's got amblyoptic nystagmus, and it's been 5 months. Okay, here's a failed PK and DMEK. So 2 previous grafts. So this unfortunate gentleman had a complicated phaco, had a secondary glaucoma, had a mitomycin C trap, which didn't work. There was an IOL exchange and then a Barveld. After the Barveld, basically, there's a lot of synechia and had a PK done, 360-degree PAS. That, of course, failed hand motion vision. So this patient came to me like this. I thought I was pretty smart. Look at this beautiful surgery I did back in 2017. I broke all the PAS, had a full, nice, deep chamber, and I did a DMEK. This patient was very happy with me. 612 vision, chamber, I think you can just see everything's deep here, and I thought that's it. But over the next few weeks to months, the angles started to zip up again. The PAS came back with a vengeance. Pressure went up, had the TCP done, micropulse, didn't work, had a second Ahmed valve, well, a Barveld and then an Ahmed. And that really damaged the graft. The PS recurred 270 degrees. The DMEK graft failed, and we ended up with this again. So I'm not going to repeat the same thing again. We're not going to do a synechiolysis and do DMEK. So in this case, I removed the iris, put in the secondary implant. Now, unfortunately, I don't have the video for the iris implant, but it's almost the same here. This is what we did after removing the iris and implanting the artificial iris. You can see the AC is very deep now. Okay, and this is what I call DMEK ready. So here's the DMEK. And doing a DMEK graft in a previous PK, a little bit more tricky. I will refine the DMEK graft to generally fit the PK so there's no overlap. And one has to be a little bit more accurate in centering the graft. There's obviously high dislocation rate, but you will appreciate that this is not that much different from a normal DMEK now because we have normalized the angles and the pupil is centered and a relatively small opening. You can see there's one tube here, another tube there. So this patient has gone through a lot, and that's the graft. Okay, and then once you close the wound, you can then inject. A good trick is I will press down on the wound to prevent air bubble coming out. That's your DMEK. And this is what it looks like. This patient achieved 612 vision. We don't have a cell count. We couldn't get a cell count value, but the cornea is very thin. It's 460 microns, 10 months follow-up, 612. Okay, this lady, 26-year-old, had a iris tumor, which turned out to be a non-malignant ciliary body leiomyoma, which abutted the cornea, went right back into the vitreous, measured 15 millimeters in diameter, which I removed through a scleral trapdoor, and largely aniridic because it affected all the iris. So this patient ended up with aniridia with PAS in the periphery. There was a retinal detachment. We fixed that. We did a scleral fixation of an implant and cornea decompensated PL vision. I inserted the iris in May. I mentioned about be careful with the iris, with the IOL. The IOL was decentered, one loop was out. I had to go in again and reposition that loop, but that was okay. And then we performed a DMEK, and this is what the eye looks like. 1,800 cells, 645, she's got epiretinal membrane and cystone macular edema, so she's still undergoing treatment, but 15 months, she's doing well. Finally, this is my last case, angle closure glaucoma. This patient had primary angle closure glaucoma, he's 68-year-old, one-eyed patient, the other eye's lost to glaucoma. He had a trab in that eye, and that was an obvious complication. The post-op AC, I think, was flat. AC reformed, but 320 degrees of extensive PAS. So you can see there that this all the way around is about 2 to 3 millimeter rim of PAS. So this chamber is really small now and very shallow. And he also had a very dense cataract. Okay, so, you know, phaco itself was a bit frightening. And at 660 vision, you can see the PAS all the way around here. Okay, so I managed to convince the patient that he didn't need this iris anymore. Here was a different technique. The capsule is, if it was intact with my phaco, then I would put it in the bag. And here we're trimming slightly smaller diameter. No sutures now. I still had the fiber version. You can use the non-fiber, but this, I'm rolling it up and going to insert it in an IOL cartridge. So the phaco I did well already. I put in a capsular tension ring just to stretch the bag, and we're loading the iris into the IOL. This is an AMO cartridge, which they recommend. This is fine. I think most cartridges will be okay. The idea is to keep the pupil opening upwards. You can just see the opening there. And so as you insert it, just to make sure it doesn't rotate. So the phaco has been done. I've removed the iris with a vitrectomy, and you can see the capsular bag. The capsular bag, you'll see a bit better later on, has to be a little bit smaller, so about 5 millimeters. And we have to stain the capsular bag because we have to put it under the bag. So capsular tension ring in, IOLs in, and here I'm billowing the anterior capsule. That stretches the opening to create a gap between the anterior capsule and the implant. And very important, make sure that the front edge of the iris is in the bag and this pupil is facing forward so it doesn't flip the other way around. Now this is pretty bulky, and one has to be quite careful because if you split this bag, it's a problem. Okay, and then it's a little bit of maneuvering to open up the flanges of this iris and to tuck slowly under viscoelastic control to put this in. But this actually was a much shorter operation because we didn't have to suture anything, you know, a lot less inflammation, I think, without the suturing. And this iris, artificial iris, is in the bag. You just have to be careful not to press too hard, and the danger here is to make sure you don't rip the anterior capsule. You can do this quite okay. Just take your time, get the edges folded in. And once it goes in, then you'll see that it's pretty straightforward. Almost there, the center there. Okay, so this is what it looked like post-op. And then I'm going to skip through. I think we're running a bit short of time, but basically we're talking about the same procedure. Really not much difference here. There we go. There. So this patient did very well. He's got glaucomatous optic atrophy. So 624 is his best vision. We've got 6 months follow-up. So finally, my last case. This is what happens with COVID. Another bad case, fungal keratitis, therapeutic graft done, large graft, 270 degrees of PAS, secondary glaucoma. I implanted the artificial iris in February this year, pre-COVID lockdown. This is what it looked like. This slide shows you why we need to stage the procedure. There's fibrin and a bit of blood. We need to get that all cleared up, which was all ready for DMEK. I ordered the cornea. It came in, got flight delay because of the COVID lockdown across the globe. It got stuck in Korea, basically, and that was it. We could not use the tissue. And then the government in Singapore pronounced the complete lockdown, no surgery, and 6 months delay. Basically, the cornea turned opaque, 1.4 millimeters thick. I discussed this with the patient, and we decided against a DMEK. And so I did a PK 2 weeks ago. She's 6'9", but you know, this is a high-risk graft, so we'll see. So these are my 8 cases here. I've done 8 cases now. This is the second stage, the first stage with all the iris implants, and these are all the after the DMEK cases. So how well does keratoplasty do? Well, we know PK is bad. This is the data from the Singapore Corneal Transplant Registry. That's our PK. That's DSEC, which is not much different from our renal transplant patients. This is DALK and DMEK. So I think for the first time, DALK and DMEK can be better corneal transplant procedures compared to solid organs. That's why we should be doing DMEK. So I think the challenge for DMEK goes on. DMEK today is probably the best option when we can do it for endothelial dysfunction, but remains challenging. The pull-through endo-in approach provides good control of the donor, reduces the risk of donor eversion, and allows you with the endoglide to provide a more controlled chamber depth. But we're not only talking about chamber depth. Now, the new approach is to normalize the anatomy of the chamber, to clear the decks, clearing the way to make DMEK a little bit easier. And with this, we use the artificial iris now to do this. And with better surgical control, we can now perform more complex cases where anterior segment and chamber abnormalities may make conventional DMEK a real challenge. Okay, thank you very much. That's the end of my talk. I do want to acknowledge Eversight. Certainly, Eversight has been a tremendous organization to help patients in Singapore and in the region. We get a lot of corneas now after COVID from Eversight, and we thank you very much.
Thank you so much, Dr. Tan. I do have a couple of questions. As a reminder to everyone, if you do have a question, it can be typed in the Q&A panel at the bottom of your screen. So we do have a question from Dr. Jennifer Park. Thank you, Dr. Tan, for your very interesting talk. When inserting the DMEK graft, are you both holding onto the graft and also tapping and injecting gas, or do you need an assistant to do one of those things?
No, I don't have the luxury of an assistant. I do everything myself. So basically, I'm always holding. So I grab the forceps with my left hand, and that left hand doesn't move. So it is a bit challenging. I tap with the right hand. So it's only one-handed tapping, but you know, you're controlling the donor with your left hand. And you have to learn to inject gas with one hand. So it's a one-handed technique. So I inject a little bit of gas just to make sure the donor's floating up and it's not going to coil up again. And once I have enough gas, a sort of medium-sized bubble, I can let go. Everything's stable. I close the wound a bit more, and then I have both hands free to inject the full gas bubble. Okay, so I do everything with one hand. So a little bit trickier. Hope that answers the question.
And then the second part of that question is, do you do PPV or anterior vitrectomy for the sutured iris implant procedure?
Yes, you have to. I think it's very important because you're putting forceps in the pars plana area, you have vitreous there, you're gonna have vitreous strands everywhere. So a really important aspect is to make sure that your anterior vitreous face has been largely removed. And that means pushing the iris one side and then, you know, making the vitrectomy area, the vitrectomizing clear around where your sutures are going to be and your pull through is. Yes, so sometimes if you're worried, then you should get a retinal colleague to help you to do that. Because otherwise you'll see peak pupil and you can get a traction retinal detachment subsequently.
Okay, and then we have a question from Roni Sayeg, the rebubbling rate with the trifold technique, and then what is the rebubbling with iris reconstruction cases?
So I've done 8 cases. I've had to rebubble one patient. That was the PK, previous PK that you saw. That was really because the edge was lifting off from the PK. It wasn't a major detachment. I just thought it's safe to rebubble. So I've done a lot, haven't done a lot of cases. With the DMEK endoglide, generally about 5%. Okay.
Okay, and then we have a comment from Dr. Ahmed Omar. Very impressive. Thank you, Dr. Tan. Would you fashion a peripheral iridotomy in the artificial iris?
Yeah, so that's what the website recommends. Basically, you'd cut little 4 dog-ear corners from each side. I did that for one case, and I realized, if you look very carefully, there, you know, a 1 millimeter gap difference. The iris trafine 1 mm smaller than the white to white leaves definite gaps all the way around. There's no way that you can seal that area. So actually, I forgot to put the PIs, and then I just don't anymore. I don't think those PIs are necessary if you have undersized the artificial iris according to what the manufacturer says. There's always going to be some gaps, and so I don't worry about that.
Okay, and this may be somewhat of a repeat question, but do you see any difference in rebubbling rate with the artificial iris, and is there any difference in the rebubbling process when you do have to do it?
No difference. Like I said, I just did one You know, I need not have rebubbled that case, but I just wanted to make it. A lot of my patients from overseas, so they can't stay in Singapore that long. So I just rebubble that patient. Yeah, I don't think there'll be any difference.
Okay, that looks like the end of our questions. I don't see anything else coming in the queue. So I would like to thank everyone again for joining us today. The webinar has been recorded and will be available on our website to view on demand. A very special thank you to you, Dr. Tan, especially for joining us so early in the morning and for serving as today's speaker and for providing us with your invaluable expertise on this subject. So I hope everyone has a great evening. Thanks again, Dr. Tan.
Thank you. You're most welcome.
Bye-bye.